lesson, I'm going to explain postpartum hemorrhage and your role in providing care for this patient. Let's dive right into what postpartum is exactly. So it is blood loss, and it is a lot of blood loss. It can occur early or it could be late. So early would be in the first 24 hours, and late will be after 24 hours. Postpartum hemorrhages can occur up to 2 weeks after delivery. So this is the point where the patient's at home and she has this happen to her, which can be super scary and dangerous. We once had a patient who had gone home after having twins, which was actually her 5th and 6th child. So she had had a lot of babies. So she was already at risk because her uterus was tired, had been overstretched with twins and having several babies. And so she was more at risk, more bleeding. Well, apparently she had been calling over several days to the nurse at the doctor's office and let them know that she was bleeding and bleeding more than what she thought she should. The nurse did not pass it along probably as best as it should have been. And so this continued. And then around 2 a.m. in the morning, she woke up to the bathroom and a clot the size of a Frisbee came out, which is huge. She instantly started to pass out, and thankfully she could chuck something, a hair product off the bathroom counter at her husband to wake him up. So he could call 911. This would have been a totally different story if she hadn't gotten his attention. So she was taken to the hospital and they just couldn't get the bleeding to stop. So she had to have a hysterectomy done, which is the worst case scenario for a hemorrhage. And the doctor said she had never been so close to losing a patient and having a patient die on her from this. The patient stayed in the ICU for a few days and was given blood products, and all ended well. But this is where we're also so thankful that a pregnant patient has that extra blood volume. So this is one of the great reasons why. So you have excess bleeding happen, that extra blood volume is there to help support your body. So now how much blood loss is going to be too much blood loss? So for a vaginal delivery, we say that anything over 500 mLs of blood loss is too much. We're calling this a postpartum hemorrhage. And for a C-section, because they're expected to lose a little bit more, right? They're in surgery. So anything over 1,000 milliliters of blood loss for a patient having a C-section is going to be our postpartum hemorrhage. Now, the doctors, they are forever always underestimating their estimated blood loss. So unless everything is being weighed to quantify the blood loss, it's probably off by a couple hundred. So keep in that mind, not just that you might have a patient pass a clot after delivery that weighs or is equal to 100 milliliters of blood loss. Might not seem bad, but if that patient's already lost 400 from a vaginal delivery, then adding that blood loss in from that clot is going to be a postpartum hemorrhage. So you got to keep an eye on all that and keep everything in your mind of how much the patient's lost at delivery and then what she's continuing to lose. The other thing is if your patient's saturating a pad in 15 minutes, or less, or is found in a puddle of blood, that is going to be a problem. We don't want them to saturate pads that quickly and, of course, not be in a puddle of blood. So don't forget those checks pads under the patient. Sometimes that blood is collecting and pooling behind them, and you might not be aware of that. So don't forget to check those checks pads as well. Now let's look at, the different causes. All right, so there are many reasons that a hemorrhage can happen. Our number one reason is going to be uterine atony. That's our number one risk or number one cause of a hemorrhage. So this is when, remember, that uterus is boggy. It's not firm. It's got no tone. It's without tone, so atony. So it doesn't firm up. It's unable to contract the way that it should be. So that means it's going to bleed. Remember, boggy means bleed. So there could also be an injury that's occurred in the birth canal from delivery. So it could be maybe a laceration that's occurred that maybe wasn't repaired properly, or an episiotomy that was cut. So those kinds of things could cause injury and cause a hemorrhage. Retained placenta. So this is just where tissue from the placenta was retained. And what happens is the body's going to bleed, try to get it out of there because it doesn't belong there anymore, right? The placenta's job is done and it needs to be gone. So if you have retained placenta, could cause a postpartum hemorrhage to occur. It's going to cause excessive bleeding. And then our other reason are bleeding disorders. So these are patients that are not clotting properly, DIC being one of those and one of the most dangerous. So who is at risk? Everyone is at risk. It can happen to anyone, but some people are going to be at a greater risk. So let's talk about that. So those that have had a history of a previous hemorrhage, if they have that history, they could possibly do it again. So they're at risk. Anyone that has had a uterus that's been overstretched and distended, because think about it, that uterus has to get back to its regular size. It's got to contract more. So it's overstretched. So these would be people that are pregnant with multiples, so twins or triplets, a large for gestational age fetus, that large baby taking up room, overstretching that uterus. If they have polyhydramnios, so extra fluid that's overstretching the uterus, that's going to put them at risk. A tired uterus. So a tired uterus is also going to put them at risk because the uterus is tired. It doesn't want to contract, doesn't want to do what it's supposed to do after delivery. So these patients are the people that have carried multiple pregnancies. So not multiples like twins, but multiple pregnancies. So that's your patient that, it's in her 9th pregnancy or something like that. So greater risk because that uterus has been stretched multiple times. Our biggest fear is always that patient that, comes in and she's a G10, P9, come rolling in to have a baby because that uterus has been so stretched out. Also, patients that have labor that's been prolonged. So their uterus has been already contracting during this long labor, and now it's tired and it doesn't want to contract anymore. On the other side of that, a precipitous delivery. So those patients that come in and deliver super fast, they're also going to be at risk because the uterus is like, what just happened? And can't quite get its act together and contract the way that it should. Our placental abruption. So if you recall, placental abruption, which was talked about previous lesson, is when that placenta comes detached before it should. The uterus fills with blood. So they're already going to be at a risk because they're bleeding more because of that abruption. Placenta previa, these patients also are bleeding already because that placenta is in the wrong spot. If it's over the cervix, and it's going to be losing blood, or mom will be losing blood from that. Preeclamptic patients, they're to increase risk as well. And then also assisted delivery patients. So that's those vacuum forceps deliveries to get the baby out. You're just more at risk because it could cause tissue damage and things like that. So now let's look at what you're going to assess in this patient. So what's this patient going to look like? What are her symptoms? She's going to have increased bleeding, of course, is our number one symptom, right? She's having a postpartum hemorrhage. That's what it's all about. And then there's going to be lots of other different symptoms to talk about, but it's going to depend on the severity and the type. So that's, what's caused the hemorrhage. So you might have a patient that's completely asymptomatic or a patient with all of the symptoms. So it just depends on the cause. So a boggy uterus, you might assess her and find that her uterus is boggy. So that's that atony that's occurred. That uterus is not contracting. So just massage it and firm that back up. You might have a patient that's oozing or trickling blood. So, they got a laceration, something like that, a placenta that's still in there, and they're just going to be oozing or trickling blood. It might not seem like a lot, but it can add up. And then the patient might show symptoms of shock, restlessness. So these are patients that are going to have changes in their vital signs. I will tell you that vital signs are a late sign that something has happened or that a hemorrhage has happened. So the patient might be tachycardic, restless, pale, diaphoretic, hypotensive, weak, all those things. The patient being restless and tachycardic are early signs. So restless and tachycardia. Those are our early signs. But if your patient's already hypotensive, then something might have been missed because being hypotensive is a later sign of hemorrhage. It takes time for the body to show that symptom. Our management is always going to be prevention, right? We don't want a patient to have a postpartum hemorrhage and be trying to fix it. We want to prevent. So fundal massage and assessment is going to be done really frequently to watch for bleeding. So after delivery, this massage and checking is done every 15 minutes for the first hour. Okay, so she'll get 4 checks. And then it's going to be every 30 minutes times 2. And then every 4, I should say times 2 times. And then every hour. And that'll be times 4 checks. So frequent assessment of that. At any time that the bleeding is noted to be heavy, the fundal height is going to be measured so that we can get an idea of where that fundus is. And this is our fundal massage is going to help to contract those muscle fibers to get a firm uterus and stop the bleeding. Our blood loss is estimated so we know how much is lost. To quantify it, so we know exactly how much the patient has lost, we're going to weigh things. So 1 gram equals 1 milliliter of blood. So if you lose a clot, your patient loses a clot and it weighs 100 grams, then she has lost 100 mLs of blood. And then of course we'll subtract whatever, the Chuck's pad, whatever it's on, to get the weight. So that's how we'll quantify it. Lab work is going to be done. Typically an H&H is done at the time, but also maybe 6 hours later or about that, just to see the effects and how the patient is handling what's her H&H doing 6 hours later. And then medications. So our medications are going to be oxytocin, methylorganamine, and carboprost. And so these are all medications that can be given to help contract those fibers of the uterus and get it to contract and firm up. So our D&C and hysterectomy. So the D&C can help clean out if we have placental tissue. The patient might be taken back for a D&C to clean out everything, evacuate the uterus. And then a hysterectomy. Now the hysterectomy is going to be kind of our last resort. If bleeding won't stop and it's really severe, then that's our last resort. Our education. So the patient's going to need to be educated on when to call the provider or the nurse at the hospital when she is concerned about something. So when would she call? If she's having excess bleeding, if she's soaking a pad in 15 minutes, if she's passing any clots, we're concerned about that. Also, when she's home, they shouldn't soak a pad in more than an hour. So the 15-minute thing is when we really worry when they're in the hospital right after delivery. Of course, we would still worry about that time, but an hour will be our other time frame for after the patient, was discharged home. We're going to tell them, hey, if you soak a pad in an hour, you're doing too much. You need to stop and you need to call the doctor. And then our clots. If there's any clots being passed, we want to know about that. And then we want her to know that she is still at risk for a postpartum hemorrhage for up to 2 weeks, because we don't want her to brush off any of this excess bleeding as being, I'm bleeding, I just need to rest, or whatever it may be. We want her to know that she's still at risk so that she can know that it's important to still call. Our concepts are clotting and perfusion, because we are concerned with perfusion because of blood loss, and we need clotting to occur, of course, to stop this blood loss. All right, let's review our key points to know. So uterine atony, this is our number one cause of a postpartum hemorrhage. It's classified as blood loss of 500 mLs for a vaginal or 1,000 mLs for a C-section. And then symptoms might be hypovolemia, are going to be hypovolemia. So there's blood loss, we have tachycardia, and then our hypotension, which is our late symptom, but does happen. And our medications. So the absolute, or the medications that we need to give are, and will absolutely be done just to help contract those fibers, are oxytocin, the methylorganamine, and carboprost. So those will contract those fibers. And remember that a hysterectomy is going to be our treatment for this if the medications don't work. So our last resort, a hysterectomy. Make sure you check out the resources attached to this lesson. Pay attention to who is at risk and how we treat it. Now go out and be your best selves today. And as always, happy nursing.